Good evening. Today's topic is MRI of the ankle, and today we'll discuss some of the more commoner things for which MRI of the ankle is referred to. Many abnormalities in the bone, soft tissues are demonstrated much earlier than the MRI before they become evident on other modalities. And soft tissue resolution, non-invasive nature, and multiplanar capabilities of MRI make it a very valuable and a useful tool for the assessment of soft tissue disorders of the ankle, especially the ligaments, tendons, and soft tissue, other soft tissue structures such as nerves. And in case of osseous structures, the insufficiency fractures, osteochondral fractures, bone contusions, and osteonecrosis, and transient marrow edema. These are better demonstrated on the MRI, and they're demonstrated quite early in comparison to other imaging modalities. So coming to the imaging technique, all three planes, that is axial, coronal, and sagittal planes, are used parallel to the tabletop. The patient is usually positioned supine with the foot in about 20-degree plantar flexion. The plantar flexion mainly is useful for decreasing the magic angle effect, which we'll discuss it a little bit later. And then it improves the fat planes between the tendons, and hence allows better visualization of the peroneal tendon and the calcaneofibular ligament, which are located adjacent to each other. And the surface extremity coil is used to enhance the spatial resolution. Usually a 12 to 16 centimeter field of view is used with a matrix of 256 or 512, 3 to 5 mm sections, and with 1 mm intervals are usually preferred. Marrow abnormalities are best evaluated on the T1 and stir sequences. Use of contrast as and when required, especially when evaluating tumors, infections, etc. Brief anatomy about the ankle joint. Ankle is a synovial joint of hinge variety formed by the articular surfaces of the distal tibia, fibula, and talus. The articular surface of the distal tibia and fibula, along with the ligaments, form a sort of mortise like with which the talar dome fits into. The joint is surrounded by the capsule, which is attached superiorly to the articular surface of the tibia and the malleoli, and inferiorly to the talus around the upper articular surface. The capsule is strengthened by the condensations of fascia, which are referred to as the ligaments, and surrounded by the tendons. The ankle ligaments are divided into a medial group, a lateral group, and a syndesmotic group, which is basically the thickening of the interosseous membrane. The tendons around the ankle are divided into an anterior compartment, a posterior compartment, a medial and lateral compartments. The normal tendon anatomy. The tendons appear as low signal intensity structures on all sequences. As usual, the T1 weighted images provide good anatomical detail, whereas the pathology is best assessed with T2 images. And for assessing the Achilles, sagittal images are also very useful. The various tendon abnormalities include the tenosynovitis, degeneration, tears, subluxation or dislocation. Subluxations are more common in the peroneal groups. Then various abnormalities like cholesterol crystal depositions as seen in xanthomas, calcification or uric acid deposition as seen in gout can also be seen. So the magic angle produces increased signal within the normal tendons when the structures form an angle of about 55 degrees with the main magnetic vector. The magic angle phenomenon is seen in the proton density and gradient sequences, and most commonly seen in the tibialis posterior tendon at its navicular attachment. And to minimize the effect of the magic angle, the foot and ankle are usually imaged in the 20-degree plantar flexion. So this is the normal tendon anatomy and the corresponding tendons. The extensor tendons are 4: tibialis anterior, extensor hallucis longus, extensor digitorum, and peroneus. The medial compartment tendons are the tibialis posterior, flexor digitorum, flexor hallucis, and the lateral compartment tendons include the peroneus, and the posterior compartment tendons are the Achilles and the plantaris. So coming to some more detailed discussion on the individual compartment tendons. The Achilles, the posterior ankle tendons include the Achilles and the plantaris. The Achilles is the largest tendon in the body, is usually has a flat or concave anterior margin on axial images. And when it is diffusely thickened and abnormal, it becomes convex. The normal tendon measures up to 7 mm in AP dimension, so anything more than 7 mm is abnormal. The Achilles tendon does not have tendon sheath, and so it cannot have a tenosynovitis, but it has a paratenon, so it can go for a paratendinitis. And the paratenon is seen as a thin line of intermediate signal intensity on the axial images. The plantaris is a small tendon which lies anteromedial to the Achilles tendon, and the high signal fat separates the two structures. The tears of Achilles tendon usually occur 4 cm above the calcaneal insertion or at the musculocutaneous junction. The retrocalcaneal bursa is located between the tendon and the posterior aspect of the calcaneus, and the tendo-Achilles bursa is located posterior to the tendon, that is within the subcutaneous fat. These are the two bursa which are in relation to the tendo-Achilles. So these are the images. Normal T1 image sagittal of the Achilles tendon, normal T1, and this is the normal axial PD images, PD fat sat images of the Achilles tendon. This is a tendon sagittal image demonstrating a near total thickness, near full thickness tear of the tendo-Achilles with a defect and surrounding edema/hemorrhage. And this is a T1 sagittal image again demonstrating a full thickness tear. The tendon is discontinuous with a wavy margin and there is edema around the tendon. So the same axial image demonstrating a complete absence of the tendon here with surrounding edema. These are images depicting partial tendon tears. We can see the tendon is diffusely thickened with interstitial high signals suggestive of a interstitial partial thickness tear. However, the integrity of the tendon is maintained. Similar axial image demonstrating loss of the normal concavity of the tendon, which is becoming convex, and increased AP diameter. Similar image on the sagittal. The medial group tendons include the tibialis posterior, which attaches to the navicular cuneiforms at the base of 1st to 4th metatarsals, and most tears occur at the medial malleolus. The tendon tibialis posterior is an important tendon because it supports the longitudinal arch of the foot, and injury to it can predispose for flat foot. The flexor digitorum longus is rarely involved in abnormalities, and it passes lateral to the tibialis posterior and inserts into the distal phalanges 2nd to 5th toe. The flexor hallucis passes beneath the sustentaculum talus, which acts as a pulley for the tendon and is inserted into the first to distal phalanx. The tendon is more commonly affected with the tenosynovitis, but it has to be remembered that the sheath of the flexor hallucis communicates with the ankle joint, and presence of fluid in the tendon per se is quite common, especially with with ankle joint effusion. So normal axial images, normal T1 axial image demonstrating the tibialis posterior, extensor digitorum, flexor digitorum, flexor hallucis, and this is the image demonstrating fluid surrounding the tibialis posterior tendon with a septation, suggestive of the tenosynovitis of tibialis posterior tendon. The lateral group tendons include the peroneal brevis and a longus tendon, which pass posterior and lateral to the inferior to the lateral malleolus within the retromalleolar groove. The brevis tendon is anterior to the longus, is more flatter and broader, whereas the longus is more rounded. So the brevis tendon is more flat, whereas the longus is more rounded. The peroneal tendons are held together by the superior retinaculum. The split tears of the tendon are more common in the peroneal brevis tendon, and the peroneal tendons have a tendency to sublux or dislocate, especially associated with tears of the superior peroneal retinaculum. And the diagnosis is made on MRI if the tendons are located lateral to the distal fibula rather than the normal posterior portion. Normally, the tibialis peroneal tendons are posterior to the lateral malleolus, and if they are located lateral to it, a possibility of a subluxation should be thought of. And conditions such as shallow retromalleolar glue can predispose to subluxation. These are the images demonstrating the normal peroneal tendons. And images demonstrating edema of the peroneal tendons. This is the image, sagittal image demonstrating the split tear of the peroneus brevis. You can see that the tendon is split with two portions, and this is tendinosis or severe degree of interstitial tear involving the peroneus brevis tendon. The anterior ankle tendons, there are 4 tendons. From medial to lateral, they are tibialis anterior, extensor hallucis, extensor digitorum, and peroneus tertius. The anterior group of ankle tendons are mainly serve as the dorsiflexors of foot and ankle. They are usually not affected in pathology, and the tibialis anterior tendon is the most commonly affected. So if you look at the images from medial to lateral, tibialis anterior, extensor digitorum, extensor hallucis, and peroneus tertius. And axial image demonstrating edema and thickening of the tibialis anterior tendon, that is suggestive of tenosynovitis, such as the tendinosis of the tibialis anterior. Coming to impingement syndromes, the most common is the anterolateral impingement. There is also posterior impingement and anterior impingement. They are less common. So the most common is the anterolateral impingement. Anterolateral impingement is produced by entrapment of abnormal tissue in the anterolateral gutter of the ankle. The gutter is a space bounded anteriorly by the anterior tibiofibular and talofibular ligaments, medially by the talus, and laterally by the fibula. Superiorly, the space extends into the tibiofibular syndesmosis and inferiorly extends up to the calcaneofibular ligament. And the gutter, which is common site for the loose bodies. The abnormal tissues include hypertrophied synovium, scar tissue related to ligament injuries, or sometimes the accessory fascicles of a normal ligament. So the diagnosis is usually made by identifying abnormal soft tissue deep to the anterior tibiofibular or talofibular ligaments, because normally the space should contain only fat which is bright on T1. So anything other than fat in that space is abnormal. So if you look at these are the schematic diagram, talus, fibula, and this is the anterolateral gutter. These are the images, axial image at the level of the anterior talofibular ligament demonstrates some scar tissue in the region of the anterolateral gutter, that is just adjacent to the anterior talofibular ligament. The same findings are seen in this image also, the scar tissue. Next, the sinus tarsi syndrome. The sinus tarsi is a cone-shaped space between the talus and the calcaneus. Normally, it contains fat ligament. The ligaments are the cervical ligament and the intraosseous ligament, the neurovascular structures, and the posterior and a portion of the posterior subtalar joint capsule. The syndrome is characterized by pain along the lateral aspect of the foot and a feeling of instability. On routine MRs, it's difficult to identify sometimes the normal ligaments, but usually the sinus tarsi space is usually occupied by high signal intensity fat on T1. So anything abnormal will usually associate with obliteration of the fat and is replaced by either edema or scar tissue. So if you look at the schematic diagram of the sinus tarsi, there are two ligaments. One is the cervical ligament and the other is the intraosseous ligament. T1 weighted sagittal image demonstrating cervical intraosseous ligament and normal high signal intensity fat. Sagittal T1 image demonstrating obliteration of the normal fat, and we see some T1 hypointense structures within the sinus tarsi suggestive of scarring. It's either related to ligament injury or some other inflammatory pathology. Same finding, scarring with T1 hypointensity within the sinus tarsi and loss of normal fat. Plantar fasciitis. Plantar fascia is a condensation of fibrous tissue originating from the plantar aspect of the calcaneal tuberosity. It has a central thick portion and a thinner medial and lateral expansions. The central portion attaches to the plantar aspect of the phalanges and is about 4 mm thick. The fascia predominantly is composed of fibrous tissue and hence is of low signal in all sequences. The fasciitis is an inflammatory condition that causes pain and tenderness at the calcaneal attachment. The MR features of the include edema of the fascia at the attachment along with edema in the adjacent bone, that is at the calcaneal attachment. Sometimes there can be rupture of the fascia. This usually occurs in the mid portion with associated edema and hemorrhage. This is a normal T1 fat sat image demonstrating the central portion of the plantar fascia getting attached to the calcaneus, and distally the attachment is not shown and it is hypointense on all sequence. This is abnormal image demonstrating slight thickening and edema of the plantar fascia at the calcaneal attachment as well as some edema in the adjacent bone. So diagnostic of plantar fasciitis. Plantar fibromatosis is proliferation of the fibrous tissue along the medial and lateral aspects of the foot and presents as either single or multiple nodules along the plantar aspect. Usually there are low to intermediate signal on both T1 and T2 and some amount of heterogeneous enhancement on the post-contrast studies. Usually the upper margins is infiltrative and grow into the deeper compartments, whereas the lower margin is well defined and is delineated by the fat. This is the normal plantar fascia with fat. This is the thickening of the focal thickening of the plantar fascia. Hypointense signal on T1 suggestive of a fibroma or fibromatosis with surrounding fat which is well preserved. The tarsal tunnel is a fibroosseous tunnel which is located on the medial side of the ankle and hindfoot, extending from the medial malleolus to the navicular bone. The talus and the sustentaculum tali forms the lateral wall, and medially the flexor retinaculum and abductor hallucis longus. The contents of the tarsal tunnel include posterior tibial nerve, artery, vein, tibialis posterior, and the two flexor tendons. So structures which can cause compression of the nerve can be either intrinsic or extrinsic. The common cause include the gangliosis related to the flexor tendons or the tibialis posterior, nerve sheath tumors related to the posterior tibial nerve, or tenosynovitis of the tendons. The extrinsic causes include varicose veins or other conditions. MRI is useful to identify the precise cause of compression, and use of contrast is sometimes necessary to distinguish between the ganglion cysts and the nerve sheath tumors, because the nerve sheath tumors usually enhance and whereas the cysts do not. So this is a T1 axial image demonstrating the normal contents of the tarsal tunnel, that is the nerve, the vessels and the tendons. This is the flexor retinaculum. So a schematic diagram demonstrating the flexor retinaculum, nerves and the vessels, and anteriorly the tendons. So any pathology of either the tendons or nerve sheath tumors or anything can compress the nerve within the canal and refer to and can cause symptoms of pain, numbness along the medial part of the foot. Tarsal coalition. Coalition is caused due to failure of proper segmentation of the tarsal bones. It can also be seen in acquired conditions such as rheumatoid arthritis or trauma. Males are more commonly affected. The two main common types of coalitions are, one is the calcaneo-navicular and the talocalcaneal, that is between the sustentaculum talus of the calcaneus and the adjacent talus at the middle subtalar joint. The symptoms usually occur due to limited movement at the subtalar joint with increased stress on the other tarsal bones and spasm of the peroneal as well as extensor tendons. Coalitions can be osseous, fibrous, cartilaginous, or usually a combination of many types. So use of MRI is to assess, especially in case of fibrous or cartilaginous coalitions, because osseous coalitions are best seen with CT, and to assess changes in adjacent structures and adjacent joints like edema of the surrounding tendons and associated degeneration of the adjacent joints. These are the CT images demonstrating abnormal fusion of the talus and the navicular, of the navicular and the sustentaculum talus. That is the calcaneo-navicular type of coalition. This is a fusion of the talus and the calcaneus. This is the talon-calcaneal type of coalition, and the MR demonstrating the fibrous coalition between the navicular and the anterior process of the calcaneus. This is the coalition which is predominantly of the fibrous type. The os trigonum syndrome The ostrigonum or the posterior process of the talus gets compressed between the posterior tibia and the posterior calcaneus during the forced plantar flexion, resulting in posterior ankle sprain. This is commonly seen in ballet dancers and football players. The MRI features include marrow edema in the bones or in the synchondrosis of the ostrigonum, as well as edema of the surrounding structures. There is usually compression of the adjacent flexor hallucis longus tendon, which may lead to tenosynovitis or tendinosis of the tendon. MR image demonstrating the ostrigonum with edema, surrounding edema, as well as edema of the synchondrosis. This is a T1 image demonstrating same features, and this is the star image demonstrating edema in the synchondrosis as well as surrounding edema of the ostrigonum. Osteochondral fractures are seen in inversion and eversion injuries of the ankle. The associated ligament injuries are also quite common with the osteochondral fractures. The dome of talus gets impacted against the tibia. Both the medial and lateral talar domes are equally affected. The osteochondral fractures can range from mild marrow edema to true fractures with involvement of the overlying cartilage. So, uses MRI in osteochondral injuries is to assess for the fracture and to see if the loose body is stable or not. The osteochondral fractures of the talar dome are classified into 4 stages based on the integrity of the overlying articular cartilage and the condition of the subchondral fragment. That is, in stage 1 there is just edema of the subchondral bone, but the overlying cartilage is preserved. Second stage is there is partial detachment of the articular cartilage and the subchondral bone. In stage 3 there is total detachment of the articular cartilage as well as the subchondral bone, but the fragment is within the defect. In stage 4 the fragment is completely detached and is away from the fracture site but is within the joint cavity. That is, in the later stages it becomes a loose body. These are some of the images. Coronal image of the ankle demonstrating some edema in the medial talar dome. There is also associated edema of the deltoid ligament. This is a more advanced stage of the osteochondral injury, where there is defect in the cartilage as well as the bone, and there is subchondral cysts. This is the stage 3 fracture. Similarly, coronal image of the same sagittal image demonstrating a stage 3 osteochondral injury with a underlying subchondral cyst. Osteonecrosis typically occurs in the talus as a result of talar neck fractures with vascular compromise of the bone at the level of the sinus tarsi. The osteonecrosis of the navicular can also occur in children, which is referred to as the Kohler's disease, and radiographically can be seen as sclerosed irregular bone with fragmentation. The main use of MRI is to assess the integrity of the fracture fragments, integrity and viability of the fracture fragments. So, this is a T1 axial image demonstrating a focus of osteonecrosis, which is seen on CT on the X-ray as increased density sclerotic lesion. Here it is seen as a sclerotic lesion with a well-defined rim. Coming to the ligamentous anatomy, the MRI, the ligaments appear as thin, low signal intensity structures between adjacent bones, and they become apparent because of the surrounding high signal fat. Many of the ligaments appear heterogeneous because of the interposition of fat, especially with the posterior talofibular ligament and the tibiotalar component with deltoid ligament. For better assessment of the ligaments and to visualize its full course, the ankle is evaluated in plantar and dorsiflexion. So among the lateral group of ligaments, the tibiofibular are seen on the axial and coronal images of the ankle at the level of the tibial plafond and talar dome. They extend from the distal articular surfaces of tibia and fibula. They appear striated and sometimes discontinuous because of the fat between the fascicles of the ligaments. The talofibular ligaments are seen slightly lower down to the tibiofibular ligaments on the axial images, and the anterior talofibular appears as a thin linear band extending from the talus to the lateral malleolus, whereas the posterior talofibular has a more fan-shaped insertion and demonstrates heterogeneity because of the interposition of fat between the muscle planes, between the tendon fascicles. Normal anatomy of the anterior and posterior tibiofibular ligaments appearing as thin lines, sometimes discontinuous. Schematic diagram: anterior and posterior tibiofibular ligament. Schematic diagram of the anterior and posterior talofibular ligaments, a few axial images slightly lower to the tibiofibular ligament. So anterior talofibular, thin linear line; posterior talofibular, more thicker line, more thicker ligament with a heterogeneous signal because of the fat, and the ligaments are better seen on these fat sat images, especially when there is some joint effusion. Anterior tibio-talofibular and posterior talofibular. Images demonstrating the partial thickness tear of the anterior talofibular and complete thickness and full thickness tear of the anterior talofibular ligaments. Normally, the ligament is seen to extend from the fibula to the talus. So you can see this is a torn end. Similarly, this is a torn end. This is a full thickness tear, and this ligament is seen with attenuation of the ligament. This is a partial thickness tear. The calcaneofibular ligament is seen as a low signal intensity structure parallel to the lateral calcaneal wall on the axial images, and on the coronal images as a low intensity structure from the lateral malleolus to the calcaneus. The deltoid is one of the strong ligaments in the ankle. It has four components which is separated into superficial and deep parts. These are visualized on both axial and coronal images. The superficial part takes origin from the medial malleolus, attaches to the navicular sustentaculum talus and the posterior talus. The deeper part has a more striated appearance, that is again because of the presence of fat between the tendon fascicles, and extends from the medial malleolus to the medial surface of the talus. So this is a normal deltoid ligament with superficial part, deep part, superficial part extending from the medial malleolus to the sustentaculum talus, and the deep part extending from the medial malleolus to the talus, demonstrating the striated appearance of the deeper part extending. This is again axial image demonstrating striated appearance of the deeper part. Complete thickness tears of the deltoid are rare, and usually severe injuries are associated with the finding. Partial thickness tears and sprains are more common in the deltoid, demonstrating increased signal in the deeper part of the deltoid ligament. Similar finding, interstitial tear of the deeper portion of the deltoid ligament. This is normal anatomy of the, this is the calcaneofibular ligament extending from the fibula to the calcaneus. We can see some altered signal surrounding edema of the calcaneofibular ligament, suggestive of the partial thickness tear. Thank you.